into Spanish live. The most esteemed faculty.
Then you get rid of an awful lot of sloppy thinking.
So, but we have different, given that there's metallic portions, or asynchronous portions.
Portions 1 at this hour, 8 o'clock my time. Again, tell you about this patient, a 2-month-old, full term now.
Concept of virtual education, break barriers of geography.
Good afternoon or good evening. Welcome to the Current Concepts and Controversies, How I Do It. Wonderful from all over the world joining us today. We have close to about watching us from every continent. This is a very, very exciting show, and I want to thank everyone for joining us. I want to go over some basics, and then we're going to get right into the first thing. That there will be technical glitches. This is a very new technology, and it's been working great for about 3 years, but every time there's some things that go just how it goes. So I want you to bear with us. What I will tell you is if you find that your browser is online, close your browser completely and restart it again. That goes a little bit faster. I want to, today, what we're going to do is have several lectures, and then after two or open up a panel discussions for people to talk to each other, share ideas, want to either chat or call in, talk to us, tell us what you want to hear. The purpose of this is today. I want, if you have your computer on a wireless system, you will get a better connection if you are hardwired. We have Afghanistan, Argentina, Australia, Bahrain, Brazil, Canada, Chile, China, Colombia, Costa Rica, Ecuador, Finland, Germany, Greece, Indonesia, Ireland, Japan, Latvia, Mexico, Oman, Peru, Portugal, Qatar, Montenegro, South Korea, Spain, Switzerland, United States, and Venezuela. We want to thank all of you, our partners from around the world, joining us today to try to make care for children across the world. I want to thank our partners that have made this show possible. The Childress Institute for Pediatric Trauma, which we're going to explain more about, really been the primary sponsor and has put this show together for us, and we want to thank the mission of improving the care for children worldwide. Also, the Pediatric Trauma Society, Children's National Medical Center, and the CIPT. Thanks for joining us. We have many centers around the world that are broadcasting this. All you all have noticed the chat room here. Please and ask what we really encourage call-ins. That really helps. We will offer technical support both within the Adobe room and in the virtual environment. This is the first time we're trying this today. We'll see how it goes. There's a technical support. Look at what the sponsors have to show you. The call-in number. I'll tell you what it is now, and then we will 866-579-7901. Please call that number anytime during the want to hear what you have to say. This course will be recorded and shown on the website after about 4 to 6 weeks. So don't worry if you don't have a day and goes wrong with your internet The whole thing will be recorded, and if you paid for registration, show after the show exists. For those of you who want CME, we will be offering the CME link at the very end of the course, where we will put a slide up to show you how to get your CME certificate. So I'd like to today introduce my co-directors, who really are the these are the guys that know about trauma. First, I'd like to introduce Dr. Eichelberger is the professor of surgery and pediatrics at the National Medical Center in Washington, D.C., and has been the man who trained me, so anything that I do wrong, that's isn't to blame. Joining us today.
Well, it's a real pleasure. It's a real good time. We thank you so much. It's been great to be able to hook onto your star and make sure that everybody around the world, we really appreciate that very much. We are happy to be here today. All the physicians around the world, hopefully you'll be able to contribute to us. You put forth so that we can all have a great debate today. This really should be a lot. Eu quero dizer abraço grande para todos os brasileiros que são. Vamos dar debate hoje que vai ser espetáculo. Vocês fazer palpite de todos os negócios que nós estamos discutindo hoje, tá bem? And also I want to thank Children's National Medical Center. By the way, I'm from Brazil. So I was born in Brazil, and my mother's Brazilian. We've had a great time putting this together. I want to thank the Children's National Medical Center for making sure that I had the opportunity to participate in this. And I want to thank Dr. Meredith for including the project with the Childress Institute. So thank you so much. It's a wonderful thing that you're doing.
That's been good. Well, and that's a nice segue to my other co-director to my right here, Dr. T. Myers, Professor and Chairman, Department of Surgery at Wake Forest University in Salem, North Carolina, and is the Executive Director, is that the right title? That's Executive Director of the Childress Institute for Pediatric Trauma. And it's an honor to have you here. And I'm hoping you could tell us a little bit about Childress and what exactly.
And the problem of pediatric trauma, as everyone on this knows, we're talking about the #1 killer of kids in America, of kids in many countries in the world. So it's and it comes up so infrequently enough. Hospital people are uncomfortable, so it's a big problem, and getting education out about this is really important. I mean, it's really important. Todd and everyone here is an organization of an important donor named Richard Childress, who came to realize with us that we've got to do something about this. Kids are dying every day. It needs to be improved. So the Childress Institute is raising money for public policy so that things that can be done at the federal level can improve trauma care. Get research done to answer the questions about how to manage injured kids. Is just translating what was done with adults into a smaller size for kids, and that's proven not to always be true. Training people trauma is a deal for their endeavor, and improving the care for injured kids everywhere, and disseminates the knowledge that we currently have, and getting the number of kids that are number of places that are really expert at treating kids elevated in the world.
Yeah, that's great, and it's so exciting for us to be able to work with Childress in this mission, and I'm hoping that today is just one step forward in the mission of Childress to help. Thank you both for joining us. So I'd like to now move on to the show. I'd like to introduce our first speaker, who is Dr. Kenneth Azarow. Ken, are you there? Dr. Azarow? Yeah, I can hear you. Welcome. Dr. Azarow, Professor of Surgery at the University of Nebraska, Children's Hospital and Medical Center in Omaha, Nebraska, and Dr. Azarow is going to Dr. Azarow.
Thank you, Todd. Thank you, Dr. Meredith, Dr. Eichelberger, and to my friends and colleagues around the world. It's an absolute pleasure to be here to the symposium. Let me just start by showing you what we're going to be talking about today. So what you see in front of you is a 4-month-old who was in close proximity to a blast. The mom was killed at the scene, and we're looking at facial burn, airway burn, closed head injury. You won't be surprised to find out there's perforated tympanic membranes and a pneumothorax. The chest is not visualized on this picture, and this is typical, and we focus on the head and airway with infants, and I'll give you in the talk, and this will set up really two main topics to set up my. First is really the mechanism of the blast, and the second is how that specific to what happens in adults. So when we look at, any of you know that we divide this into 5, and you'll not be surprised to know that some of this is not new material, and some of this is actually in 94 by Hooker, and the title was Physiological Effects of Air Concussion, and it was Publicology, and this really talks about the primary mechanism, or the barotrauma, or the shear that occurs in. The secondary injury is penetrating trauma, and that's from debris that is packed in with the explosive device. The third is blunt tooth that occurs by larger debris falling into the victim or being blown with the victim as a projectile themselves being thrown against. Fourth, or the quaternary, is the burn, and specifically the inhalation burn that we'll talk about a little bit. And then we look at bacteria, radiation, and some of the contaminants out from the smoke at the end of the explosion. Published 24, the combination of primary, secondary, tertiary, and quaternary was first described by Krohn in 1942, entitled the Physiological Effect of Blast. We move on pictorially. In the 19th, Defense Nuclear Agency formed a study group, mainly of physicists, to specifics of these pictures. Some of you will recognize are taken out of the textbook of military medicine and the casualty. Volume 5, Conventional Warfare, and these. This is taken by Richmond, and what I want to point out to you, first, you can see the external wave, the air concussive wave. That would be the start of the primary. Sees the fireball on the inside. What you don't see in between the two is the debris that can act as interest to me is researching this. The same type of effect occurs in water, and what you'll notice is these are 2 shots from time-lapse photography. The blast on the left to that wave, and then following that would be, rather than the fireball you saw in the previous cover comes through. Of interest is that physics, the actual wave characteristics are completely, you're going from water to air and vice versa on our patient. The second part to emphasize to many of you is we've had an experience, unfortunately so, in the last 10 years to be involved in blast injuries. You can see that the Joint Theater Trauma Registry from which this data is taken, and I'll thank one of my co-hosts for these slides together for us, is that approximately 5,000 blast injuries. And of interest to us is over 1,000 specifically relate to children under 14. Some trends that we've noticed, and I'll emphasize how children are adults and how that affects the care when we look at it. The other thing that I will tell you is the Joint Theater Trauma environments, and this actually has an effect on the injury. First, you'll notice this is Kalat City in Afghanistan. This is here on Route 1, and you can see this is the only country, and we are dealing with wide open spaces. So if you're injured while you're traveling on Route 1, there's probably less debris in a blast in which would look like many of your urban centers, and you could last metal, plastic, etc., coming from building that you're in will affect the type of mechanism that the blast. So getting back to approximately a quarter of the children, 23%, are involved in injury. What's the opportunity to do is to get a significant number of children at the bottom line. This is one of the things we're going to focus on. So for children, the head, face, chest, and specifically burns have a much compared to adults where we're talking about extremity and pelvic injuries are listed above. The mechanism of injury in children, landmines, whereas adults mainly involved in IEDs. The blasts for children, they're much closer to the ground, so blast is the head and the airway issues, whereas adults, you see the explosion coming from underneath, so you have more prevalent in adults, although I will show you a child who had a significant pelvic injury in a few slides. And obviously in children, they're not wearing body armor, and a proportion so you don't in our experience are. So now looking at we look specifically at the lungs. The contusion and edema occurs to a greater effect in children, not absent, obviously very sick. And some of this actually has to do with the total amount of body water, as most of the percentage of body water decreases as you increase in age. As you can imagine those explosive pictures I showed you earlier, of the pressure wave will also have a tremendous effect. It can affect some solid organs well. So when we talk about primary blast injury, don't just talk about mastoid air cells, gas-filled structures in the body. We also talk about fluid-filled structures in the body, and this can have a significant effect not only on lung, but also on brain, liver, spleen. It filled with fluid and blood are not necessarily given a free pass when it comes to these injuries. When we think about, again, the upper half of the body in children, a little bit more prevalent in children than adults, although certainly not absent in both, and then we look at the overall patterns really come into play in children and infants, and this eventually will also determine how well they do with the injury. How just overall, and this is again just a summary for adults and children, just open but closed head, and then you're also looking at the blast effect occurring in head, and we're looking at chest, the inhalation burn along with the barotrauma that occurs in the abdomen, both solid and penetrating problems, and then we talk about burn all over on the skin. I'm going to show you a slide in 1 second as in some of the GU effects. And then we talk about this is a child, a 6-year-old who actually some of you out there interested in the care of. I think there were approximately 20 surgeons who took care of this child in 2000. This was a 6-year-old who was holding an unexploded ordnance. He put it he stepped over top and then it exploded upward. Rectal injury, obviously scrotum and testicle, and then a very large deep soft tissue injury. He was managed with the urethral colostomy, rectal repair, and then wound vac for the majority of his deep soft tissue wounds. And this is an unusual presentation for a child that you do have to worry about the whole body, even though I'm going to show you morbidity and mortality early associated with burn and head injuries. What we can see is looking at the joint data, it looks like we have 2 spikes, one very young and one very old. This is not largely population, but it is worth taking. We do see a spike in mortality in young children. I think that this is primarily due to burn and head injuries, and this does prove out on regression analysis. CU stay. Again, we see another spike in the very young, and we also see that and in hospital days. Now again, these are statistically significant, but they are trends, as many of you know who is. We transport soldiers out. The degrees of care hold on to children a little bit longer than we do adults. But the fact is that burn and head injuries tend to do worse, and they tend to be more prevalent in the younger population. So with that, I will summarize. Are hurt a little worse. They have higher mortalities. We think that's due, and it's physiological differences that make them more prone to head. Now, I will turn this back over to Dr. Meredith and Dr. Eichelberger. Hello?
Hello? All right, go ahead. Dr. Azarow, that was fantastic. Thank you very much. And as you say, to keep us on time, let's move to our next. Yeah, we'll be at the end, so please send in your questions, everyone from around the world. Blog in your questions.
Yeah, and Dr. Azarow, can you stay? Azarow, are you there?
For the panel, absolutely.
Oh, perfect. Yeah, so just stick around. You can hang out, and then we'll bring up for the panel discussion. Thank you. That was. We have a lot of questions for you. So, and I agree with what Dr. Meredith said. Type your questions. We will ask those. So we're going to move on to the next talk. Thank you, Dr. Azarow. Dr. Shellington, are you there?
I am.
Perfect. Let me introduce the Assistant Professor of Pediatrics at Rady Children's Hospital in St. San Diego, UCSD. Is that the, in there, Dr. Shellington?
Yes, it is, sir. Thank you.
Perfect. Well, thank you so much to talk to us about damage control resuscitation.
Can I just say one thing here? I mean, Dr. Shellington is a pediatric intensive care and spent time, I think 6 months, if I'm not mistaken, in Afghanistan. So he has just got out of the Navy, has a tremendous amount of experience in the whole area of an environment.
And this is a real important topic.
Yeah, and I want to thank you so much for joining us, Dr. We'll ask you questions at the end.
Terrific. And thank you for giving me the opportunity to speak this morning. To address we'll bring up that is not the view from my office that I'm showing there. It's just a nice contrast for the time. So as mentioned, I will be introducing the concept of damage control resuscitation as a new paradigm for injury and polytrauma. My plan is to discuss some of the roles that hypothermia play, and when I'm able to, I'm going to review some relevant combat experiences that made the care of these patients. As I discuss, I'm going to try to be clear about where I'm going to be presenting evidence and when I'm going to be talking about my opinions. To introduce the talk with a case to provide an example of the kind of I recently took care of a 9-year-old male who was struck by a 30,000-pound vehicle going about 25 miles an hour, 100 yards, resulting in a pelvic crush injury, and effectively had a below-the-knee left leg massive transfusion protocol, and gave him rewarmed emergency initiation of his left internal iliac artery. Eventually made it to the fixation, and he also had a diverting colostomy and essentially in the OR. This was probably a result of hypovolemia. He responded to additional. He was given 30 units of PRBCs, 30 units of FFP, and 6 units of platelets. He has survived that incident with no sequela whatsoever. And for those of you who are envisioning an MRAP in Afghanistan, this was actually a child that was hit by a trash truck. And I draw more arrows on this slide, and I've seen many slides out there that are difficult to follow. But to simplify things, we typically however, it may actually primarily cause a coagulopathy via release of cytokines and tissue factor. And this worsens your hemorrhage even before your resuscitation begins. Hemorrhage is going to lead to shock and acidosis via tissue hypoperfusion. You can develop hypothermia or environmental exposure if you're in somewhere like northern Afghanistan in the winter, or you can get that from administration of room temperature. That is something that becomes very important in the resuscitation of these children and is essential to the remainder of the talk. To talk briefly about the coagulopathy, in Afghanistan, we present this patient, this picture here, because it was a patient who had a very severe head trauma, severe bleeding on his way to us, but had severe coagulopathy. Elastometry or ROTEM, which I'll discuss a little bit later on, have demonstrated significant coagulation after brain trauma, likely as a result of this tissue factor release that I mentioned earlier. A study out of Afghanistan for critical care medicine has found that some evidence of mortality in pediatric patients. In a cohort of 744 mentioned 18 years of age, a base deficit of less than 6 or above were highly predictive of mortality with odds ratios of above 2. The tip of the hat to military field care, which is great for the patients, but not necessarily good for proving that hypothermia is related to pediatric mortality. Setting of the trauma beyond first study looking at about they actually found an adjusted odds ratio of about 2.4 for mortality in hypothermic patients, and this was using a hypothermia at less than 36 degrees. Coagulation abnormality with hypothermia. There was a second, smaller study recently results. Perhaps a bit slow to recognize these associations between hypothermia in the setting of trauma and mortality in the pediatric patient. But then there was a Canadian multi-center trial that was published back in 2008 in the New England Journal of Medicine, and what they showed was that as a therapeutic modality for TBI, the 6-month outcome in these patients tended towards an unfavorable outcome in the hypothermic patients and had a trend towards mortality. There was a U.S. cooling concerns presented in that Canadian trial, and although the results are still pending, they're rumored to be similar. So how can we practically use this evidence supporting the adipopathy, hypothermia, and acidosis in pediatrics to improve our resuscitation of these sick trauma? Isotonic crystal by driving a hyperchloremic metabolic acidosis and further diluting your coagulation. Damage control resuscitation focuses on minimizing these negative effects of crystalloid through the exclusive use of blood products once they're available. You have blood available, that is the ideal fluid to give for damage. And though it's ideally suited for resuscitation, it's available, and component therapy becomes the mainstay of DC. The ratios I'm going to present here are open to discussion, and they're going to be hotly debated. You need to give blood, FFP, and platelets, and avoid crystalloid if possible. The military used and used successfully a ratio in adults of FFP to 1 random donor unit of platelets, and a pheresis unit is going to be equal to about 4 random donor units of platelets. It's difficult to translate to pediatrics because of the volume that you're going to be giving. If you give 1 unit, shows are going to work for kids down to maybe 20 or 25 kilos, but if you get below that unit of blood, a unit of FFP and a unit of platelets, you're really going to get into, because of the sheer volume that the child's being administered. So there are very complex, if you go online to different protocols for different sized children, and if you're at a large institution where you have significant laboratory support, blood bank support, or if you have a photographic memory, please go online. For those taking care of children alone in the dark without a lot of support, what I would tell you to do is consider giving them boluses of 10 cc's per kilo PRBCs, 10 cc's per kilo of FFP, and to start, give them 10 cc's per kilo of platelets. Continue to use this ratio extensively because you will over-transfuse platelets, but this is going to be enough to get the child to survive to the operating theater where you can address the bleeding and have time care for the child. Permissive hypotension is going to be the second key thing to discuss with respect to damage control resuscitation. When you're administering your blood products, and this can be tough in kids because there's always seems to be a tendency to overtransfuse rather than go based on a per kilo basis. What you want to do is allow permissive hypotension. In a recent ad, used an adult mean arterial pressure of 50 in a damage control setting. And what they found was that using a mean arterial pressure of 50 as a goal resulted in decreased transfusion requirements, decreased IV fluid resuscitation, and decreased mortality. To translate, a MAP of 50 would mean watching an adult patient with a blood pressure of 70/40 and not resuscitated. Pediatric intensivists to do with 2 or 3-year-old children. Blood pressures would be even lower. So if you set your pediatric MAP tolerance to 50, where this adult MAP tolerance is, if you would argue that it's more restrictive than what a lot of us tend to do. This picture is a photograph taken of the operating room theater in Afghanistan after Marie, but it's to give you some idea of the sheer volume of blood products that we're talking about in these situations. You can see the one isolated bag of crystalloid over there on the floor, and the rest of these blood products are components, PRBCs, platelets, and FFP. And that's what I'm talking to the side as soon as you have access to your blood products. Now for the concern about component therapy and the preference for fresh whole blood is that there are issues with banked blood. Increased hemolysis, decreased 2,3-DPG are the two of the big ones. The decrease in 2,3-DPG shifts your oxygen dissociation curve so that you get decreased oxygen delivery to tissues. Banked blood, fresh whole blood is great if you have it, but if you don't, still comes overall when you compare it to a crystalloid-based, because in the research for my presentation, I've seen that there are centers out there in the U.S. giving 40 to 60 to 80 per kilo of crystalloid before starting a damage control process, and I do not believe that is the right way to go. Looking at, again, some U.S. trauma studies in adults, a recently published study by Brian Cotton showed that a damage control approach reduced the amount of crystalloid, reduced the amount of blood product, and the incidence of the lethal triad that was present in these all of us, it increased 24-hour and 30-day survival. Start to do more work with damage control resuscitation for into too extensively, but because we're using a blood-based, we should not use hemoglobin as a measurement of total body volume status. There seems to be a tendency to do that. You know, we want to transfuse if the hemoglobin is 7. We don't want to transfuse if the hemoglobin, which is going to have a hemoglobin of about 10, and they're going to use hemoglobin to decide when you need to transfuse. I had kids in Afghanistan who would have a hemoglobin of 12 or 13, but a CVP of 0. They were hypotensive with poor urine output, and I had to make a decision about whether I was going to sit there and resuscitate them with crystalloid, feel better about giving blood, or just give blood. In Afghanistan, I ended up realizing that giving blood reduced the total amount of volume that I was giving and just made my life a lot easier at night when I was there. But the reason why I bring this up is that there are some ICU-based studies which show that in the long term, a restrictive blood transfusion strategy is as good as a transfusion strategy. And so at some point with these patients, we may need to shift from giving a lot of blood to a little blood. And we don't know when that is, but I would say that once your patient's stable, stasis, and your patient's in a recovery phase, it's time to think about threshold. I don't know a lot of pediatric intensivists who can sit on a hemoglobin. Another new concept toward the end of the talk is the idea of thromboelastography or ROTEM. We all rely on PT, PTT, and INR to diagnose coagulopathies. And it turns out in the setting of these massive injuries, it may not be the most sensitive means of diagnosis. And so without going into the details of TEG and ROTEM, all concepts that you may be interested in that will, it provides more of a mechanical description of clot formation and breakdown, and it may be a more sensitive coagulopathy in these patients. There was a reason that this was more sensitive than PT, PTT, and INR. With respect to new concepts, hypothermia, coagulopathy, and adults are associated with a lethal triad. As we see that his base deficit gets above his base deficit gets below 6 and INR gets above 1.5, there's an increased in mortality. I would argue that the transfusion ratio for pediatric patients, but you may want to remember 10 cc's per kilo to 10 cc's per kilo as come in the door, but then back off on the platelets as you get further into your resuscitation. Think of bulimia. Allow your patients to be a little hypotensive at times. It may be good for them. It may minimize edema. And as you convalesce in the ICU, think about reducing your transfusion threshold. I'd like to acknowledge the following people who have either served in Afghanistan as pediatric intensivists or assisted me with the and I'd be happy to answer questions a little bit later on.
Fantastic information. Clear, practical, that's just wonderful.
And
Thank you.
You're talking about how great that was, so concise and really clarified all the key points. Thank you very much for that. And then you said you can stick around for the panel discussion? We're going to move on now to our next talk, blast injury treatment. Dr. Mary.
I'm here. Good morning.
Well, good morning, Dr. Edwards.
Go Army.
Dr. Eichelberger says, go Army. So much for waking up so early to be with us today. It's Dr. Edwards is a pediatric surgery at Tripler Army Medical Center in Honolulu, Hawaii, and she is going to be talking to us about blast injury treatment. Before you start, Dr. Edwards, I just want to see all of the new concepts and bibliographies of all these talks. You can find Childress booth. There's 2 Childress booths. One of them has all of these set to your computer at any time, either during or after the show. Dr. Edwards.
Could I just say one thing about Dr. Edwards? People might not know. She got back from Iraq, having 2 or 3 tours over in Afghanistan. Is the chief of pediatric surgery at the Tripler Army Hospital. We're very fortunate to have her with us, who's going to present really some very practical information. Mary, welcome.
Oh, thank you very much. I appreciate the opportunity to share some. And the facility that you're looking at is where I'm fortunate to spend most of my time. It's in a beautiful, a lot of resources to take care of injured children. And this contrasts significantly with many of the places that I've been deployed. And this is Farah province in Afghanistan, and as you stated, not a lot of resources, and unfortunately, the child of the effects that explosives can have. And one such child that I'm going to tell you about, I think, illustrates some of the principles in treating these injuries. This was an 8-year-old explosive, his neurologic status. He had obvious penetration, open fracture, and a blown right pupil. His GCS was 5. And his abdomen had this peppered appearance that I'm going to talk more about later. After consultation over the phone with the neurosurgeon in theater, the general surgeon taking care of him for me, where he was able to raise a generous skull flap to the hematoma. At the end of that procedure, the child looked like he was placed on his brain. He was transferred to the next higher level of care. Of that surgery, and what the general surgeon did, oh well, I can't find it. But basically, you can see the fracture line there, and he made burr holes along that, and where, there we go. couldn't connect the burr holes with a fracture line. Uh-oh. I'm disconnected.
That's okay. Right, Dr. You're
Connected. I'm back.
okay.
So he raised a generous skull flap, evacuated. Mute my speakers now.
It's not.
Okay. So he raised a generous skull flap. And the child was transferred. Next slide, please. So fast forward 8 hours later, and the patient not taken to the operating room. He lost vital signs, but his abdomen was expeditiously opened, and a right chest tube was placed. And between these two turned. He had a rocky ICU course for the next week or so, but was discharged 3 weeks later, and is regulating and feeding himself. So all things can out of everything. Can I get the next slide, please? What makes them unique seems to be that complex injuries are common. So injuries to more than one body cavity region are really the rule and not the exception. And talked about, this is an injury where you can certainly have a penetrating, and then finally this unique aspect of blast injury with this arm. As with most injuries that occur in wartime, preventable death, when you talk about the majority of causes of preventable, the most likely thing. So when you discuss pre-hospital hemorrhage control is probably the most important thing. Controlling the airway is certainly important, but if you control hemorrhage, you'll actually save more patients. Can I have the next slide, please? So when we talk about hemorrhage control, and it's most commonly employed is tourniquets. Can I have the previous slide, please? Recently, the ISR actually reviewed their experience with the use of, and found that although these devices really weren't designed to be used in children, they actually are quite effective in when a tourniquet is required, is similar to actually that of United States, in pediatric patients as well as adults in the setting of extremity hemorrhage. A tourniquet is a good device to implement. We reviewed our experience with pediatric blast patients in Iraq and Afghanistan, and this was the published experience in Israel as well. And again, these injuries are treated, and so CT early on can be deceptive prior to when edema sets in. And for this reason, many military neurosurgeons have advocated aggressive craniectomy to decompress the skull. Ocular fragment injuries are another thing to be aware of. in our 1,200 pediatric patients, we have nucleation or evisceration of their orbital contents. The other thing that I'd like to call your attention to in this photograph is this peppered appearance, again, of the skin, and this is due to multiple fragments impacting the casualty. Can I have the next slide, please? The chest and abdomen. Early intubation, again, is prudent before the effects of edema set in. And this peppered appearance is significant because this is due to multiple fragment injuries. And so if you see, a lot of times don't know on physical examination the degree of penetration that the fragments have had, and something needs to be done to assess for that, either with imaging or with surgery. And again, the effects of primary blast injury are to the air-filled organs, primarily the lung and intestine. And although in and of themselves, primary blast injury does lead to mortality in these casualties, it does have an additive effect when combined with the penetrating and blunt forces of the explosion. Next slide, please. So how do you treat them? Personally, I think in the operating room. There was a paper out of Iraq 2 years ago that discussed the utility of CT scan in abdominal injuries from fragments and utilizing that study to decide who you can and can't operate on. A useful tool for that. But in a clinical situation where a patient doesn't seem to be acting right, or you're worried about an injury, certainly a low threshold for laparotomy, thoracostomy, or thoracotomy is appropriate. Can I have the next slide, please? The use of temporary abdominal closure is a very good tool to have in children as well as in adults, be it with the VAC system or some combination of an adhesive dressing and drains. Certainly if you run into a damage control situation, like Dr. Shellington was discussing, the ability to take a child back is facilitated with a temporary abdominal closure. Next slide, please. I put this slide up mainly because this isn't a scenario that you normally would see in a civilian trauma center, but it is when dealing with these explosive injuries. And I have to be honest, as a pediatric surgeon, I really had found the fact that when operating on these patients, you sort of have to, pardon the cliche, but go big or go home. Everything really needs to be inspected carefully, and you really have to do a thorough exploration because you just don't know the path that these fragments are going to take through the body, or how deeply they're going to penetrate, or how many are going to penetrate. So you really have to decompress everything well. And that holds true for when you do a fasciotomy. As you can see on this patient's side, or excuse me, all of the fascial components really need to be opened well, and perfusion needs to be restored. And if you don't do that adequately, in a lot of cases, you might as well have not done it at all. Can I have the next slide, please? This is a photograph of some fragments highlighting the fact that these fragments can go pretty much anywhere they want. Next slide, please. When you talk about extremity injuries, one of the things that I think needs to be stressed is that the soft tissue injuries in the extremities are highly contaminated, and surgical debridement plays a critical role in controlling infection and sepsis. When you have a significant soft tissue injury, dealing with the fracture, external fixation is liberally employed and certainly stated is very important, followed by a vascular repair if needed. And if you run into a situation where you can't control the hemorrhage in a massively injured extremity, the life over limb concept holds in terms of resorting to amputation if needed. Next slide, please. This is a blast injury resulting in bilateral open fractures. And this is, again, that peppered appearance. And what I wanted to mention here was that even in the absence of a fracture or a major vascular injury, just the soft tissue injuries from these fragments can result in edema significant enough to ultimately require fasciotomy, and so that should be kept in mind. And this is just to exemplify sort of the deep contamination of these wounds, with debris really being brought even into very, very deep soft tissues. With burns, as Ken said, when we did our analysis of pediatric patients in Afghanistan, the injury that was most independently predictive of mortality was a burn. And I think that speaks to the fact that if you have a burn from a blast, the implication is that you were very close to the center of the blast to sustain the thermal injury from it. And as a result, multiple complicated injuries are going to be the likely scenario. And certainly when you talk about the effects of edema, when you superimpose that on a burn resuscitation, it's going to be amplified. And I think this case sort of exemplifies that. You know, this patient was obviously very close to the blast as manifested by his burn and his traumatic amputation. And you can again see the degree of soft tissue contamination in this wound that's going to require fairly aggressive debridement to get this wound under good management. And again, these are horrific injuries, but these children can survive, as was the case with this patient, and she's actually intubated to have her eyelids released for this. So new concepts, I don't think it's so much maybe new concepts as return to old concepts, but once again, the initial priority is hemorrhage control. And when you talk about getting the sort of low-hanging fruit in terms of saving the majority of people, you'll save more if you focus on controlling hemorrhage as soon as possible. I'm not saying that non-operative treatment can't be done, but the majority of these patients require at least one surgery. And so if you elect to do non-operative treatment and the patient starts not acting right, I think you have to worry that you're missing something, and the something that you're going to miss is most likely going to be dealt with in an operating room and not an ICU. And then again, the effects of edema from these injuries are going to be manifest 1 to 2 days after injury, and decompression of almost any body cavity can be required. And once again, beware of missed injuries. And you know, I'm harping on the same thing, but don't hesitate to operate. And I just say this because when I look back at my anecdotal experience with managing these patients, the only times I've regretted what I've done is when I wasn't aggressive enough about operating soon enough, exploring soon enough, debriding widely enough, making an adequate fasciotomy. So don't make the same mistakes that I did in managing these patients. And you know, certainly staging procedures is a useful thing to do, taking them back to re-explore them, re-debride them. The analogy I make is with pediatric trauma patients that are managed now in the United States, it's a very non-operative thing. It's sort of a no-contact sport, like a chess game or a chess tournament. But when you talk about managing explosive injuries, this is a full contact sport. I mean, this is ice hockey, this is football. You have to really kind of attack these injuries and be aggressive. And one final thing to speak to that, you know, as Ken mentioned, in our series, these children had more severe injuries. Their severity, their revised trauma scores were lower. They were in the ICU longer, and this was actually all statistically significant. But at the end of the day, when you compared them to, to the adults, their mortality rate, although significant, wasn't significantly higher. So there's no reason to not be as aggressive with these children as you are with the adults. And they can handle it and hopefully do well in the long run. Thank you. That's all I have.
Well, that was fantastic.
Dr. Edwards, thank you so much. We love that talk, and Dr. Eichelberger's raising his hand.